answering it. So before I conclude, I leave you as to how does it actually answers this question. And while the video is on, feel free to.
I mean, very powerful from a technology point of view, but in terms of what it goes through, number one, it understands natural language in human speech. Okay? It understands how sentences are formed, how verbs are formed. It understands puns. It understands metaphors, similes. Very powerful capability that the IBM research team came up with over the 4-year period. Then, based on that understanding, it generates a hypothesis. It generates an answer panel that you saw in Jeopardy that says, I believe the first answer could be this or this or this with a probability around it. Okay? And once the user selects a particular pathway, it understands and learns from how that system is being used. All of this is built on the massively parallel probabilistic architecture. Once I got slammed on that deterministic to probabilistic, I never used that architecture term with my daughter. But that is a pretty cool piece of technology underneath it that powers Watson. So let's now take a look at a healthcare example and how this might come together. We here have a case of a 58-year-old woman and who comes in complaining of dizziness, anorexia, dry mouth, and it kind of gets entered into a medical record. And what the system does then is starts extracting the national language from it and says, okay, given that she's having difficulty swallowing, given that she's got fever and dry mouth, it seems like these could be the potential diagnosis models where it could be a case of influenza, it could be diabetes, UTI. So based on that first piece of information in the medical record, Watson's beginning to say these could be some potential conditions and this level of confidence. Okay, so it starts off with influenza first. Then,
okay, sorry about that piece of clarity, which was because it was in video which was recorded, and this was live. Based on an extracted information which was available in what was called as a free text typed format. There was no former RDBMS and there was no database and data warehouse and data query. Nobody wrote anything that what am I looking for. Okay, we've only made it to understand that these were the possible diagnosis or the disease codes, which is all about ICD. These are the potential procedure codes. And these are the medications, which typically for the US, it is NDC. For India, we use pretty much anything from the same syntax. Okay? So now it starts reading the text. If you look at what has been given on this side and starts answering this.
And you start adding on top of that the family history. Then you say, this particular lady's family history has that her mother had cancer in the past, a bladder cancer, they had Graves' disease in the family, and then Watson starts adding that and says, when I overlay that, it seems like to me that it looks more like diabetes. Then on top of it, you add another piece of information saying, here's the history, here's what's happened with her in the last 4 years. When she came in, these were the kinds of treatments that were given to her over the last few years, and then Watson looks at it and says, you know what? Based on what I'm learning now from the symptoms, from the family history and the patient history, I don't think it's diabetes or influenza. Seems to me it could be UTI. Okay? And then last but not the least, we start adding on top of it medications. Okay, what are the medications that have been prescribed and what has been the impact of it? Then Watson looks at all the medical journals, looks at the patient records and says, based on all of this stuff and the test data, I believe with a fair degree of confidence that UTI is what she is going with, and that is the assistance that is provided at a pretty fast pace to the doctor or the nurse who is administering that patient. So pretty powerful stuff in how unstructured data and big data is pulled together
Okay, that was pretty much on what we had on Watson. Is it available? The answer is yes. What is it doing now? It does its best, which is save money for the payers, because that is where the immediate returns are. And next logical extension from healthcare is what do you do? Work with the financial institutions to save fraud and money. So it has gone to work in Citi. Is it working for hospitals? Yes, it started working for hospitals. But right now it's only an oncologist. You're training it to be a cardiologist. Pretty soon we would have a multi-speciality Watson available. We only have an interesting discussion from the management. In a country like India, what if If somebody can pick up a simple smartphone, start speaking in Bhojpuri, which is a local dialect in remote Bihar, right, and says that these were my conditions and I'm not sure, should I be visiting a doctor or I should walk down to my nearby quack, whom we all know, right, and ask for some treatment. And the idea is that there is someone who is as expert as a super specialist or a specialist of specialists and comes back and gives you an answer in your local language. Thank you.
Being transmitted in any form that's actioned by the physician. At the same time, I want to tell you a bit about where next generation technologies are going. That's really my mission today, is to talk about information and communications technologies in emergency care, give you a bit of an idea, for example, which in the past couple years have been spawning very excitedly and excitingly. The lack of connectivity in general between emergency medical service providers and treatment facilities that they serve and where they deliver patients, and for the information about what needs to happen to this patient. The second element that I'd like to give you an insight about is where technology can go, and really where the industry is inviting opportunity for innovation for companies like ours, and hopefully solutions from there with Karoom as well as the other presenters on stage to essentially bring the emergency medical response industry tools and technologies to help them close the data gap between emergency responders and those care facilities. So with that, I'm going to turn my face away and I'm going to show you a brief video, and then I'm going to take you through some slides real quick. Are you all seeing the video?
Did you know that fewer than 50% of ambulance providers in America use any technology in their ambulances? Rest capture their patient transport details from the time medics arrive on scene to the handoff at the hospital. A double-sided sheet of paper. The average transport time is over 20 minutes.
I apologize. Hold on, I think I need to share my screen here. There we go. There we go.
Did you know that fewer than 50% of ambulance providers in America use any technology in ambulances? The rest capture their patient transport details from the time medics arrive on scene to the handoff at the hospital on a double-sided sheet of paper. But the average transport time is over 20 minutes, and the typical hospital handoff takes just 45 seconds. Roughly 46% of patient data are lost in the process, increasing time to treatment, the risk of medical errors, and the crush of rising healthcare costs.
So again, what I'm going to talk to you about today, are you seeing the slides?
Yes, we can see. Please go on.
Thank you. Thank you. So I'm going to talk to you about sort of where the problem is and where we're going to go with it. With that brief overview, in general, particularly in the United States, but also in other locations around the world that are taking a lead on technology, when we talk about a connected health center, this is essentially what we see. We see technologies that are designed for the IT department, for the CTOs, for the clinicians. We see acronyms being thrown out from EHRs to PHRs to CPOEs, cloud this, optimization, and so on and so forth. When we first started in this industry, we identified a particular problem, and that was, no matter how optimized one's hospital is, if you have a piece of paper that walks in through the emergency department door, you have a fundamental breach point. When you have 27 minutes in transit in the United States, and certainly much longer in places around the world that have larger distances between incident scene and treatment facility, someone has to document what has gone on both at the incident scene and to the patient in transit. But the average handoff to the hospital, again, is just roughly 45 to 60 seconds. What you end up dealing with is a life or death game, a phone tag, essentially, or a telephone, where information may or may not be transmitted from the first responder to the receiving facility. It may or may not be transmitted correctly which can, of course, affect clinical care. And ultimately, the question is, who would know and who else needs to know about those patients? In the United States, because less than 50% of EMS agencies use technology, what you're seeing here in front of you, hopefully, is a single day's output, actually 3 out of 5 pieces of paper that were generated around a single set of calls in an emergency response agency outside the University of Pittsburgh Medical Center, which many of you may know. For better or worse, when facilities refer to their intake of digital technology, they generally are limiting that information currently to a 12-lead EKG. But as the physicians in the room will most likely agree, as we've consulted with physicians across the country, the 12-lead information, a cardiac signal, or any other single data point without context about the patient itself ultimately doesn't provide a whole lot of information about that patient and about the care that they're going to need to receive. The rate of false positives is, in many cases, frighteningly high. What you end up dealing with is an expensive, inefficient, and error-prone process where the time in treatment, the time in transit, and the time to handoff all end up being redundant. We've taken, for example, judging from a person, but I do have to admit that I find technology amazing, and I'm even able to speak to you today and show you this material. So thank you again. Ultimately, because of this break